It's my pleasure to co-chair this session. Gastrointestinal 3 with my co-chair, Mr. Nabil Alizai from United Kingdom. There is an important announcement before we start that we need you all to give out the feedback assessment sheet before receiving the certificates. It's very important. You will not be allowed to receive certificates or attendance without filling out the attendance feedback sheet. And I'm sure your feedback will be great. All of us have enjoyed the workshop, the wonderful scientific program. So I will start with the first presentation. That's sleepless, socialist, harmonic capital, laparoscopic and appendectomy in children. It's impossible. Zenon Popovic from Croatia. 7-minute presentation.
Chairman, ladies and gentlemen, I will present you the approach of laparoscopic appendectomy using the device to secure the base of the appendix. So, although not yet the gold standard, actually the laparoscopic appendectomy has become the dominant method of the treatment of acute appendicitis. The benefits of laparoscopic approach are well known, but during this procedure, the most important thing for surgeon is actually to ensure the safe cutting and achieve hemostasis, and today we have many devices which may be used. So actually the next very important question is how to secure the base of the appendix. Today several methods of securing the base of the appendix are available. The linear staplers, but they are very expensive. Actually there is no recommendation of routine use of the endoscopic staplers to secure the base of the appendix. Then the widely used the endoscopic glue and the polymeric or titanium clip. All of these techniques have their advantages and disadvantages, and the rate of complications regarding the intra-abdominal abscess regarding the literature is 2 to 5%. So recently, clipless or sutureless laparoscopic harmonic scalpel or ligature appendectomy has been introduced, and up to date 5 studies and 1 meta-analysis has been published. So for this study, between January to... Can you start the video, please? Between the January 2019 and May 2021, we included 312 children. We performed 2 study groups. First one was a polymeric clip group and another one harmonic scalpel. The median age was 11 years, and we include all patients up to 17 years of age who underwent laparoscopic appendectomy. And yeah, it will be too long if the only video goes, so please back to the presentation. So the primary outcome of this study was intraoperative and postoperative complication rate between 2 study groups, and the secondary outcome, duration of surgery, length of hospital stay, and time required to both peristalsis to return. So we used a 5 mm supraumbilical trocar and 2 lateral trocars, laparoscope, grasper, harmonic scalpel, and endoscopic retrieval back if needed. So regarding the 2 groups, we can see that both groups were symmetric in regards to demographic data and preoperative analysis of laboratory parameters. And regarding the pathological analysis, we can see actually that similar findings were found between the 2 groups. And now for the treatment outcomes, the postoperative fever was much frequently found in the polymeric clip group than the harmonic scalpel group. And regarding complications, 10 complications were recorded in the polymeric clip group, 3 cases of postoperative ileus, paralytic ileus, and 7 cases of abscess, which of them 3 required reduced surgery. And in the harmonic scalpel group, there was no complications. Duration of surgery, median duration was 30 minutes in the polymeric clip group and 21 minutes in the harmonic scalpel group. And the duration of hospital stay was overall So, for the conclusion, Cliplex harmonic laparoscopic appendectomy is a safe and effective method for treatment of acute appendicitis and is associated with a lesser number of complications and shorter duration of surgery compared to the laparoscopic appendectomy where the clip is used. But the randomized multi-center study or larger sample are needed to determine these results. So just for the technique, because we did not see the video, we just ligate in a stepwise maneuver the base of the appendix. So you start very distally, go a little bit proximally, and then you cut it. In sequence, there is no pressure, and it's not expected to have any complications. Thank you.
Thank you so much, Zenon. It's really interesting. Before receiving question, I would like to ask the audience, anyone have tried this technique before? Please raise your hand. No one. Okay. I would like to add one thing more. Your co-author, Haysam Rashwan, is from my department in Alexandria.
Yes, yes.
So I've been following this for some time.
20 patients in this study as well.
Yeah.
Yes.
Professor, want to say?
Thank you. Thank you very much for this presentation, of course. And I have two small questions. First, is you use a varus needle. And as everybody knows, in Europe is not so frequent recommendation to keep this way, to introduce a new molecule. The second one is regarding the balance and difference between the Europe and the United States regarding the stapler. And I don't know if Steve is in the room, but of course, in the majority of the cases for appendectomy, in the States they use the stapler, 5mm stapler. So, what are your comments on this question?
Thank you. Regarding the varus needle, it was a method that in our house is usually used, so we've never had any complications. Definitely in the very small children we use the open technique to introduce the first trocar, but in the older children we use the varus needle. But regarding the stapler, I read a lot of literature and I know that there is a practice in the United States to use the staplers, but I don't believe this is because the stapler is very expensive. I don't think it's very neat to do this. And also the harmonic stapler is expensive too, but we re-sterilize it and we perform study where we show that the re-sterilized instrument is the same effective regarding the terminal lateral injury and regarding the effectiveness. So,
all right. For the sake of time, I'd like to thank you so much for interesting.
yeah,
Yes.
that is the question.
Last quick comment and quick answer, please.
I'm Daniela Claudius from Italy. Thank you so much for your presentation. The first question is, Dita, I probably missed it, but were two randomized group or was just before we used one technique and then we used the other one? The second question, in group A, how many of the abscesses that you have were due to slippage or misclipped of the appendix, or do you think it's just a difference because the second technique is better?
I cannot say that the second technique is better because we are just introducing it. We performed about 150 cases up to now, and we had no complications. In the first group, in all patients, the clips were properly placed, but I don't know why the abscess happened. And the first question was regarding, it was not a randomized study. Yeah. So I said in conclusion that randomized studies are needed to do this. Thank you.
All right, thank you so much.
The next paper is from Pamplona, Spain, presented by Javier Montero, and it's on complete bowel exploration and polypectomy combining laparoscopy and sequential intraoperative enteroscopy and Fischer syndrome at case report.
Thank you very much. Well, we want to present a case report of a 12-year-old male which was diagnosed with Pepstein syndrome, which occurred to the emergency department because he had abdominal pain. In the first ultrasound study, an individual introspection was identified without ischemia and without any kind of bowel compromise, but on the follow-up ultrasounds, which were performed because the symptoms were maintained, two more introspections were identified, one of them ileopolia. Due to the findings, an exploratory laparotomy was performed through a McCurry, and a manual reduction of the intussusception was performed. The main cause of the ileocolonic intussusception was a polypectomy, which was removed with a polypectomy. You have the picture. And in this surgical procedure, we opt to endoscopical examination and serial polypectomy as a new surgical research that can be used in this kind of patients. Here you have the endoscope to the bowel loop, and here you have also the polyps and the endoscopic examination in the surgical field. Summarizing, we start with a barrel incision, we manually reduce, we did the polypectomy, which was causing the ileocolonic intussusception, and then through the endoscopic examination, we performed 8 polypectomies without any kind of incidents. There were no postoperative complications. The patient was discharged 6 days after the procedure, and all the histopathological reports were compatible with an anatomical report. Any further complication was identified, and no new surgical intervention was required. As a discussion more than a conclusion, polyps in this kind of syndrome are usually benign, but they cause significant morbidity. They are quite frequent and widely distributed in the bowel. The treatment of these kind of patients is quite complex because of the multiple polyps in multiple locations, and sometimes these patients need aggressive surgeries. We believe this technique of this variation provides a resource to make an overall inspection of the bowel and a resection of the polyps through just filling porotomies, which can be easily sutured after that, in a patient that already needed a surgical procedure. Thank you very much.
Thank you very much for taking time. Let's open to the floor. Any questions?
Thank you very much. I think this is a typical case of the pandemic because chemical was in the same case. Message is take off the mask of the patient because you see the perioral pigmentation. We didn't see it because the mask wasn't taken off. So it's a nice case. Thank you very much.
Thank you.
Yeah, ask a question, please. In your department, are these procedures done by surgeons or gastroenterologists?
In our department, upper and lower gastrointestinal endoscopy are performed by us, the pediatric surgeons, so this procedure was entirely performed by pediatric surgeons.
Okay, thank you. Any other questions? That's excellent. We've saved 1.5 minutes. Thank you.
Thank you.
The next presentation is about short and long-term outcomes of surgery for duodenal atresia, a single-center experience and literature review, and will be given by Alessandra Preziosi from Milan, Italy.
Thanks. Good morning, everyone. So, as we all know, laparoscopic repair of congenital duodenal obstruction has become popularized in the last 20 years. The published literature shows that laparoscopic repair is safe and effective, but only a few reports compare minimally invasive approach with open approach, and there is still controversy about the value of minimally invasive approach. So the aim of our study was to evaluate short and long-term outcomes of patients underwent open repair for duodenal atresia, and to compare the outcomes of these patients with group of patients who underwent minimally invasive repair. We retrospectively reviewed patients affected by duodenal atresia operated in our hospital, Policlinico of Milano, from January 2011 to January 2021, and we compared their outcomes with the minimally invasive repair described in literature. We considered preoperative data, so prenatal ultrasound, associated anomalies, gestational age of birth, and birth weight. Operative data, the age of surgery, the surgical technique, the operative time, and eventual intraoperative complications. And postoperative data, the time of starting feeding, the full length of feeding, and eventual early and late complications. We found 17 patients in our period time. About the preoperative data, 12 of them had prenatal diagnosis, 6 of them trisomy 21, and 3 out of 6 also cardiac defects. The median gestational age was 36 weeks, and the median birth weight 2,720 grams. Considering the operative data then, the median age of surgery was 3 days. All of them underwent an open diamond shaped adenostomy. The median operative time was 75 minutes, and there weren't any intraoperative complications. Considering the post-operative data, the median time to initial feeding was 10 days. The median time to reach the full enteral feeding was 20 days, and there weren't any anastomotic leaks or anastomotic strictures, neither other complications. So we wanted to compare these outcomes with the minimal invasive surgery described in literature, and we reviewed the most recent published papers. And we found that considering the operative time in minimal invasive surgery is much longer, reaching up to 280 minutes compared to our experience in open surgery. But if we consider the time to initial feeding and the time to full enteral feeding, we can see on the table that is much shorter in minimal invasive surgery compared to open approach in our experience. Looking at the complications, we can see that is pretty high, the conversion rate, reaching up 35% in one study. There are different causes for that. Usually is the lack of visualization of the retroperitoneal part of duodenum. Considering the anastomotic strictures, we had 2 cases, like has a high one, and then other complications described were incisional hernia, displacement of transanastomotic tube, and infections. So, to conclude, even if laparoscopic surgery for the anesthesia is a challenging surgery, their outcomes are comparable between open and laparoscopic approach. We have to consider that the most recent literature shows that for minimal invasive approach there is a longer operative time, a higher complication rate, but a shorter time to establish feeds. Of course, the limits of these studies that no prospective or randomized studies have been published yet, so to have a more accurate conclusion, we will need to have randomized clinical trials in the future. Thank you for your attention. We will be happy to have you next year in Milan for our pediatric colorectal and pelvic workshop. Thanks.
Thank you so much and congratulations for your nice results. Before taking questions, I would like again to ask the audience who's doing laparoscopic duodenal repair for duodenal atresia. All right, this is around 25%. Okay, go ahead with your question.
Thank you very much for your presentation. So, a comment. Of course, we have a historic bias because the laparoscopic correction is a newer patient. So, of course, when we combine it, we will definitely have a bias. Actually, we start feeding the next day. So we start with clear fluid. Maybe someone started with milk already the next day, and the second post-operative day we give milk, and we didn't have any problems. We didn't have any leakage and no problems. If you look for, if you want to achieve non-greenish fluid from the stomach, you can wait for weeks because you have an open bladder. So this is not a criteria for starting or increasing the fluid. So still 7 days to start initial feeding in laparoscopic group is, to my opinion, is too late. If you don't need to start that late, you can start right away.
Yeah. Thanks for your comment. We knew that this part of the study was biased by the fact that starting the feeding depends on what the surgeon prefers to do. Some surgeons start with the NG tube is clear, other surgeons prefer to perform an upper gastrointestinal control, so it depends, but yeah, thanks for coming. Yeah?
Yeah, so if I understand well, I was advocating that duodenal anesthesia should be operated by open approach?
No, we just compare the two approaches.
But what are you training your partner now?
Sorry?
what are you doing in your department?
We
Results
just-
pretty short.
We just do the open approach.
Okay, so we are advocating an open approach in the laparoscopic congress.
It was just a comparison.
Yeah.
Well, maybe you're planning in the future to start with mainly invasive, because we have to differentiate between the learning curve period where you have a long operating time and high rate of conversion, but after you overcome this, the results can be comparable with benefit of early start. So I may ask you, would you like in the future to start this program?
Yes, of course. We just think that considering it's a challenging surgery, skilled and experienced minimally invasive surgeons in our team should start as first one.
So we'll wait for the results next year.
Yeah.
All right, thank you so much.
Thank you.
Can I just second what my friend said, that there are a lot of denominators in when you start treatment and how they feel, and being aggressive is one of them, whether they have a tactic or not. So I think we have to be very aggressive and feeding these children, no matter what approach you use.
Okay. Thanks.
Thank you so much.
Thank you. So the next paper is from Bratislava, presented by Korenkova, or laparoscopy for interception and 10-year experience.
Thank you, Chairman, ladies and gentlemen. Intussusception is one of the most common causes of abdominal pain in infants and toddlers, and the management is very well established. Also, at our institution, all patients with positive symptoms and ultrasound confirmed diagnosis are admitted to the department, and all stable patients after preparation undergo hydrostatic reduction under general anesthesia with ultrasound guidance, and where they are successful, we wait for full rehabilitation and they are discharged. In unsuccessful cases or in patients that are unstable with, for example, statutory signs of perforation, we indicate surgery directly without hydrostatic reduction. We retrospectively analyze 10-year period, and 324 patients were enrolled to study, from whom 18 didn't need any other therapy because we observed spontaneous reduction. 5%, another 18 patients proceed directly to surgery due to aortic status due to perforation, and 288 patients undergo hydrostatic reduction, which was successful in 87%. 38 patients in whom hydrostatic reduction wasn't successful were proceeded to surgery, so we totally have in our group 56 patients, 33 with 20 of them were treated by laparoscopy, 36 by laparotomy. Distribution of sex was similar in both groups. Majority of patients presented with abdominal pain and vomiting. It was a little bit higher number of enterorrhagia in surgical group, but without statistical significance. Also, 27% patients had concomitant respiratory infect. Range of age at presentation was between 3 weeks to 70 years, but there was no statistical difference between conservative and surgically treated patients. Neither we didn't confirm correlation of higher age with secondary intussusception. We have in surgically treated group 12 patients with ileal intussusception. All of them were secondary. The rest was mainly ileocolic primary intussusception. 4 of them were secondary. Regarding the type of surgery, we need to take into account the etiology of intussusception. So in type of primary intussusception, reduction with fixation was performed in majority of patients. Just in 3 of them, the resection and another intestinal anastomosis was needed due to perforation, hemorrhagic necrosis. In secondary intussusception, in all patients, of course, we need to perform resection with anastomosis. We perform laparoscopy by three-port approach, 5 mm object in umbilical port and 2 ports working in left basal and hypogastrium, 3 of 5 mm. In past, we perform also the fixation of the intestine, but it wasn't really well, so we abandoned it. Laparoscopy failed in 4 cases. The first patient was after the previous laparoscopy, intussusception reduction, and intestinal fixation. As you see, the surgeon was struggled and wasn't successful with reduction. Also, there was a risk of tearing of serosa, so we converted. Another autistic patient was also the first presentation of Poisonier's syndrome, and after reduction through umbilical port, we performed leg resection and intestinal anastomosis. Duration of surgery was a little bit lower in the laparoscopic group, but it wasn't really statistically significant. Only significant factor was length of hospital stay. It was shorter in laparoscopic group. Even we excluded the patients with secondary intussusception. Recurrence was seen in 2 patients after laparoscopy, 1 after laparotomy, and complications were higher in laparotomy group. In all of them, we had to operate on secondary for EOS. To conclude, we can tell that laparoscopy is safe, effective, and feasible choice in stable patients with intussusception, either after unsuccessful hydrostatic reduction or even in secondary intussusception, when after exploration we can perform mini-laparotomy or transmural approach and a complete resection and anastomosis. It has low risk of complication, shortens significantly length of hospital stay, and is useful also in labs. Thank you for your attention.
Thank you very much for an excellent, very nicely presented, and very good data. Thank you. Open to the floor for questions.
Hello, good luck for Prague. Have you ever tried from single port, also not multi-port like laparoscopy is also very nice, invasive surgery?
I know we have performed single port in the past, but it was not included in the study, but now we don't do it.
Is this fixation suture is a routine or did I miss something? I do something wrong because I never do that at home. That's the first question. And the second question is it really effective against reoccurrence?
No, it's not effective, so this is why abandoned it, as I mentioned. We did it in the past in first 5 years of the study, but this was 10-year study, so in fact we didn't perform the fixation anymore, because we also seen relapse after fixation.
Thank you.
Thank you very much. I think if you have a child which is older than 2 years and you do a laparoscopic reduction, I would be worried that you may miss a pathological lead point. Did you have any case when you did a reduction and you found that you missed mass or whatever? So
yeah.
How do you deal with that?
Yeah, these 2 patients, they were complicated after laparoscopy. This was the tumor patients. The one we performed cytology of ascites, and we have malignant cells inside, so we need to do laparotomy. And after the second patient, there was managed by oncologists because there was susceptibility to Burkitt lymphoma.
But what's the conclusion from that? So I think it would be, we shouldn't be too minimalistic. So it's probably better to expose the bowel, for example, with Poisonier's syndrome to palpate, because you may have even bigger polyps elsewhere and you may have a relapse.
Yeah.
And with lymphoma or whatever, you maybe actually take the bowel out and palpate for the structures.
Yeah, the bowel was operated in this case, and also in follow-up, this patient underwent gastro endoscopy and also colonoscopy, and another polyps were removed by endoscopy surgery.
Thank you very much.
called video-assisted gastrostomy, an effective alternative to percutaneous access. Julio Moreno Alfonso from Spain.
Thank you very much. Well, it's quite frequent in the clinical practice to have pediatric patients in which we need to stop for feeding for at least 4 to 6 weeks. So in order to manage these patients for the nutritional way of view, there's a lot of techniques to create a gastrostomy. Although the EG is a quite established and well-known technique, if we evaluate it, the percutaneous video-assisted gastrostomy as a potential new technique in our department. Please. Video technique. Regarding our series, we operated 7 patients in last years with this technique. The mean operative time was 35 minutes. We started gastrostomy feeding in all patients 12 hours after the operation, and we didn't have any kind of complication. As conclusions, this is a simple and minimally invasive and as the main thing, a safe technique, which may be a complementary or alternative technique to EG, and also it can be performed under bacterial anesthesia to a single incision and without or with very low pneumoperitoneum. Thank you very much.
Thank you very much for your presentation. The paper is open to all comments and discussion. Yes, please, go ahead.
Thank you very much. I would be worried about the exteriorization of the mucosa. Do you have any bleeding block problems just from mechanical irritation when you have the button? Because, you know, other gastrostomy, you don't have the mucosa outside. It's very, very fragile. So, do you have any problems with that?
No, we try to be very gentle in that maneuvers. And in this series we didn't have, but we have to acknowledge as a limitation that we only have 7 patients, so it may happen.
Can I just ask a question? I couldn't see properly. Did you stitch it to the fascia of the stomach?
Yes, the stitches, the last stitches are anchored to the fascia.
You have mentioned that you can do it without pneumoperitoneum. And in the video I've seen that there is pneumoperitoneum. So which one?
Yeah. Now, the patient we presented here is like the ideal case, which did not have any comorbidities. And in this patient, we use a normal pneumoperitoneum. But what we want to stress is that in some patients, neurological patients or cardiac patients, we have performed this technique with very low pneumoperitoneum with success. So that it's also results.
So the message is it can be done without pneumoperitoneum, but if the patient does not have comorbidity, then we can do it normally. Okay, Zena?
What is the benefit of this technique if you compare it to PG? PG is easier, less invasive, you do not need additional trocar, no suturing.
The point is that what we want to stress is that in a low volume center, this is an alternative technique. Of course, we consider PG, we also do it, but we think that having alternative techniques is also a good resource for pediatric surgeons.
Because you can do PG also with control of camera if you're not sure. So, yeah.
Thank you.
I think one of the benefits is that they're putting a button in as a primary button, not using the device, the primary insertion device.
All right, if no more questions, thank you so much.
Thank you.
It's a recorded presentation, I think. It's a video.
India. Today we will be sharing the tips and tricks for a laparoscopic multi-quadrant surgery. Laparoscopic colorectal surgery in children is difficult due to the steep learning curve and the limited working space. Our patient was a 7-year-old male diagnosed with juvenile polyposis coli. After optimization of hemoglobin and albumin, we took him up for the first stage surgery, that was a laparoscopic colectomy and a Hartmann's procedure. This is a star-shaped configuration of ports which allows us to work in all the abdominal quadrants, sequentially moving from the left lower, left upper, and the right lower quadrant. So the surgery starts from the left lower quadrant. This is the position of the surgeon, screen, camera, and the working ports. We first divide the mesocolon, create a wide mesenteric window, dissect the superior rectal vessels which are clipped and divided, widen the mesencolon. The left colic vessels are dissected, doubly clipped and divided. The left ureter is identified. We then move to the left upper quadrant. The surgeon and the screen positions have to change. We divide the gastrocolic omentum, widen the mesocolon by dividing the mesocolon and mobilizing the splenic pressure. We then move to the epigastrium. The gastrocolic omentum is divided further. The middle colic vessels are identified, dissected, doubly clipped and divided. We then move to the right upper quadrant. The surgeon and the screen positions are as shown. The hepatic pressure of the colon is mobilized. The mesocolon is sequentially further divided. We then turn towards the right colon. The right colon is mobilized. The ileocolic vessels and the right colic vessels are dissected, doubly clipped and divided. The ileal branch of the ileocolic vessel is preserved for the future ileal J pouch. We see that the mesocolon is now completely divided. The colon is devascularized and is attached only by the ileum and the rectum. We then move to the pelvic region. The mesorectum is divided with harmonic. The rectum is divided with a linear cutter and stapler, which completes the Hartmann's procedure. The total colectomy specimen is then extracted through the right lower quadrant port as shown. This is the complete colectomy specimen. We check the orientation of the end ileostomy and place a drain. The boy made an uneventful recovery and was discharged by post-op day 3. This is the total colectomy specimen showing juvenile polyps with low-grade dysplasia. After 3 months, the boy underwent a laparoscopic completion protractomy with ileal J pouch anastomosis followed by stoma closure. In conclusion, laparoscopic total colectomy in children is feasible, safe, and effective with the star-shaped configuration of ports as we have shown. Thank you very much for your patience.
This was actually the second.
So you're going to present the other one as well?
Yeah.
Okay, thank you. So this one is open for questions, please.
Yeah, I have 2 questions. First, you preparing the patients before the surgery with the bar required, but you did not an anastomosis, so why do you need to prepare the patients? That's the first question. The second question is, what are you doing? Why are you doing in 2 steps? Why not doing protectomy in the same time than the ED1 approach and anastomosis?
Yeah, thank you for the question. So, answering the first question, we usually prepare these patients by bowel preparation for 24 hours. We give Pegleg and keep them, nil them out for around 24 hours. They are admitted a day prior to the surgery. And many of these patients, as this patient, they present with severe anemia and hypoproteinemia. Like the patient had hemoglobin of 6 and albumin of 2. So it's not safe to do it a single stage anastomosis. There's a long suture line on the J pouch. So we stage them. Some of them, if the patient comes in a good with good hemoglobin and albumin, you can do a single stage. It's up to you. So, but this patient was staged, so that is the answer for stage. Yeah.
Any other questions? Comments? Thank you.
Alright. Okay, so we move to the next presentation. This will be laparoscopic modified Smith procedure for wrong segment hash chronic disease, video demonstration of technique and every results.
So this one.
Other video.
Number 37.
India. As per the recent APSA practice guidelines, long segment restaurant disease is a ganglionosis extending above the junction of the descending colon and sigmoid colon. We aim to share our experience of laparoscopic modified stem cell spool tube for long segment restaurant disease in children. The index case was a 5-year-old boy who had aganglionosis extending till the descending colon. He underwent a right nostril colostomy with multiple biopsies. This is the patient position in lithotomy, and we place the ports as shown in the figure. The surgery starts by identifying the previous biopsy sites. Here we see the transition zone and the biopsy which was showing adequate ganglion cells about 5 cm above the transition zone. We create a mesopolic window, hits the colon out of the pelvis, hits the bladder. The sigmoid colon and rectum is then dissected below the peritoneal reflection towards the levator diaphragm. We stay in the plane just above the rectal serosa, which is known as the Swenson's plane, and we dissect circumferentially till we reach the levator. Here we see the levator dissected all around the rectum. Then we turn towards the mesocolon. The superior rectal vessels are clipped and divided. In this case, the descending branch of the left colic vessels was clipped and divided. As it's a long segment disease, we need to mobilize the splenic flexure by dividing the gastropolic momentum. The splenic flexure is now mobilized. We then turn to the perineum. 2 rows of anal retraction sutures are taken. Circumferential stay sutures are taken 1 cm above the dentate line. A full thickness rectal incision is given. The dissection is again performed close to the rectal serosa. The aim is to connect the perineal plane of dissection with the laparoscopic plane of dissection from above. Once the two planes meet, the rectum and colon can be pulled down easily. In this case, even after dissection, there was some tension. So we went in again and clamped the inferior mesenteric vessels. Following clamping, we see normal distal pulsations via the marginal arcade. The inferior mesenteric vessels were then doubly clipped and divided. Following this, the colon could be pulled through without tension as seen here. The level of the pull through was about 10 cm above the transition zone, and a 2-layer coloidal anastomosis was performed. A wash was given and mesopolic windows were closed. The boy made an uneventful recovery and following stoma closure had regular bowel habit. In the last 2 years, 16 children underwent laparoscopic Swenson's spool tube, out of which 3 had long segment disease, 1 till the splenic flexure and 2 extending till the descending colon. The patients with long segment disease had longer median operative time and longer length of resected bowel, which was 32 centimeters. All children have attained normal stooling pattern. 1 patient had transient post-op enterocolitis and 1 patient had transient high stool frequency. Concluding, laparoscopic modified Swenson's spool tube is a feasible, safe and effective option for long segment hospital disease in children. Thank you.
Thank you.
There is open for discussion. I would like to ask you, would you recommend only laparoscopic assisted for long segment front or regular segment also?
So we do laparoscopic assisted for regular garden variety and also for long segment.
Yeah.
We believe the laparoscopic assistance helps in the mobilization, and if you do total transanal, with more stretching of the sphincters might result in more incontinence later, but that is debatable. I know that is debatable.
Yeah, but we found that using the laparoscopy assisted for even for the regular or short segment disease has many benefits, including shortening of the transanal phase, which more and the anal stretching, which might lead to soiling. And I would like to ask you about one of the problems that should never be present in Hirschsprung disease surgery, but unfortunately there are reports about it, which is soiling and incontinence. So what about the incidence of stooling problems?
It's lesser than the open Swenson's experience, which was earlier, because I believe the laparoscopy gives you much more better visualization and magnification. You can stay in the correct plane. But in our experience, yes, I think out of 16 children, we had 2 children who had soiling and incontinence for a transient period, but they improved after a while.
So please, go ahead.
I got in my first. Thank you for the wonderful presentation. Can I ask you, in the total colonic ganglionosis, what's the preferred technique as far as it concerns anastomosis? Is it the J-pouch, is it the Duhamel or expansion? What do you think is the best for the long-term results as far as it concerns the child's soiling? what's the need for the less bowel management in the afterwards, in the later in their life?
Yeah, thank you for the question. I think it's surgeon dependent. Many people, our preferred approach is to do a long Martin's modification of the Duhamel, leave a long amyonic rectum and a little bit longer colon, and then do a Duhamel's. But I know many people will do a J pouch, and some will do a straight ilioanal. So I think it's dependent on surgeon's preference. I don't know what is the preference of the group.
The main problem is in the long segment disease.
Yes.
What's the preferred method? Because
Microphone, please.
yes, the main issue is in the long segment disease. Is Duhamel better than J pouch? So many lines of that they have suture lines.
Yeah. I mean, we will have to differentiate long segment from total colonic. Like long segment, like in this case, long segment is anything above the junction of descending colon and sigmoid. So like there you don't have to do anything different. But
total colonic?
Yeah, total colonic, either a J pouch or a long Martin's Duhamel's.
Well, I may comment on that because in total chronic diagnosis, we are talking about two extremes. One of them is ilioanal or pouch surgery. The other one is using a long blister-Martin type of Duhamel, which will lead to a higher instance of enterocolitis. My own preference, and I find very good results, is to have a short type of Duhamel with rectal pouch reaching only to the sacral promontory. So you don't have ilioanal with incontinence and frequent soiling, and don't have enterocolitis with a long blister-Martin type of.
Sorry.
Just a quick question.
You two are here. Hello?
Yeah.
Hi, Patrick from Father. Just a question and then a comment to your previous discussion. The question is, how do you define the transition zone? The question is because a single biopsy saying that it's probably transition zone doesn't give you the idea of the extent of the transition zone, and watching just at the dilation is not enough. So you should do your section, so you should read through 5 to 10 centimeter above the last ganglionic virus. This to be on the same side. But my question is, how do you define the transition zone? And then a comment to the discussion, and no way to demonstrate in literature one kind of surgery compared to the others in terms of outcomes. So the discussion probably is going to never end, and probably the best surgery is the best surgery in the hand of the surgeon. But please, can you
Quick answer.
Thank you for that question. So as you saw, sometimes you see a visible transition zone as you are seeing here. But yes, absolutely agree with you. The level of the pull-through has to be at least 5 to 10 centimeter above the first ganglionic biopsy. So you saw the multiple biopsies were taken at the time of colostomy. So I absolutely agree with you. That is a point to be taken home. Level of
Okay, thank you so much.
Thank you.
Thank you. So the last paper of the session is systemic immunity index, pathway to the diagnosis of pediatric acute appendicitis, Javier Montero from Barcelona.
Thank you very much. This is a diagnostic performance study we performed in our center in which we evaluated this novel tool, which is called the Systemic Immune Inflammatory Index, which is a ratio between the multiplication between the neutrophils and the platelets and the quotient of this result of the lymphocytes. This tool has been assessed widely in adults in different contexts, such as thromboembolism, such as neoplasms and thyroid diseases, and it has shown good performance in all these matters. So this is a prospective study that we developed between 2021 and 2022 in our center, previous ethics committee approval. We have two groups in this study with 134 patients. The first group comprises patients with non-surgical abdominal pain, controls, and the second group comprises patients with an histopathological confirmed diagnosis of pediatric acute appendicitis and 19 patients. Regarding socio-demographics, there were no difference between the groups. Regarding clinical variables, we only found a difference in the number of emetic episodes, which were significantly higher in the pediatric appendicitis group. We evaluated the leukocytes, the neutrophils, and the platelets, all of them being significantly different in both groups and higher in the appendicitis group. And when we evaluated this marker, we obtained significantly higher values in the pediatric appendicitis group. Regarding the diagnostic performance of this marker, we obtained an area under the curve value of 0.85, which is quite high, with an associated sensitivity of 89% and associated specificity of 66%. This table comprises all the variables in our study which were associated with pediatric appendicitis. The most associated, or the highest association, was the appendicular caliber by means of the ultrasonography studies, which had an odds ratio of 150, but the next one was this index that we are presenting here, which had a very high association. Previously, the neutrophil to lymphocyte ratio had been assessed in pediatric appendicitis, showing a good performance score, but we have found that this new tool presents a higher association and a higher diagnostic performance. For us, this is a new tool which can be implemented in the diagnosis of pediatric appendicitis. We want to present you. Thank you very much.
So, any questions from the floor? Do you use this regularly now?
We have tested or assessed it in our first cohort, but we have to validate it now. We are creating a second cohort in which we hope we validate it.
Are you planning to create an app for it?
Sorry?
Are you planning to make an app for it? So you just put the data in and AI will tell you what the difference are. Anyone else? Anyone using scores in diagnosing, or is it all does anyone rely on scores?
Yes, please go ahead.
So, and you have to do it in enteritis too, or how do you compare that? Because maybe, what do you do about enteritis? So, how do you compare? Do you do that? I didn't get it. Did you use it in the enteritis too, to distinguish between enteritis and
the non-surgical abdominal pain was an heterogeneous group. I mean, our inclusion criteria was a pain which was or initially mesogastric or directly in the lower right quadrant, less than 70 hours. I mean, like clinically suspected appendicitis. That was our non-surgical abdominal pain group. That's quite strict inclusion and exclusion criteria.
Thank you.
Would you like to use it for all cases or only for borderline cases? Because sometimes the clinical diagnosis ultrasonography are straightforward. You can go for surgery or you can exclude totally. So what do you think? Borderline cases or only?
In our center, we have a very good performance with ultrasonography, but there's still some complex cases in which or where the appendix is not visualized, or there's a clinical suspicion but it's not confirmed. So we are trying to develop in this course, we have later some works, new tools to improve the diagnostic performance. The main advantage of this index is that it's quite straightforward, it's easy to implement, it's economic because we only use the hemogram. So we are trying to assess useful tools in the clinical practice.
Maybe as Mr. Navid has mentioned, we need to make a mobile app for this, so that make it easier and electronic for the people. Thank you so much.
Thank you.
This will bring us to the end of the session. It was very interesting. I would like to thank all the speakers. The audience has been great with the interaction and comments and questions. I would like to thank my co-chair, Mr. Navid Alizai. And I remind you once more that you need to fill up the assessment sheet. It's very important before getting your certificate. Thank you so much. I call upon the chairs of the coming session, Ms. Irenius.